স্ক্রিনটা শেয়ার করে একটু দেখতে চাইছি। আচ্ছা, হোস্ট কে আছে?
হ্যাঁ, আপনি
আহ,
নিচে, হ্যাঁ এই তো সব হচ্ছে। হ্যাঁ, দেখা যাচ্ছে।
এক মিনিট, এক মিনিট। Good evening, everyone. I want to check my voice quality. Kaushik. Kaushik. Am I audible?
Yeah, you are audible, man.
Okay. Thank you, Abhilash.
Yeah.
My laptop is telling me that my voice quality is poor. I'm clearly audible, na?
This is clearly coming.
Okay, thank you.
Hello, Abhilash. Hello.
Hi, sir. Good evening.
Good
Good
evening,
evening, sir.
Abhilash. Good evening, Abhilash. অভিলাষ তো দেখতে
Yes, sir.
পাচ্ছি
Yes.
না তো কাউকে। ওকে তো এখনই 30 জন পার্টিসিপেন্ট জয়েন করে নিয়েছে। আচ্ছা, এই প্ল্যাটফর্মে পার্টিসিপেন্টও দেখা যাচ্ছে, তাই তো?
Yes, sir.
ওকে ফাইন,
We are live in YouTube also.
রাইট। আমাকে একটু টাইম টু টাইম মানে একটু হোয়াটসঅ্যাপ করে দিও কতজন ইউটিউবে আছে, কতজন এখানে তো আছে দেখতে পাচ্ছি, ইউটিউবে কতজন আছে।
Sure. We'll update you, sir.
একটু নাম্বারটা ইউটিউবে কতজন আছে জানিয়ে দিও, ওটা রিপোর্ট লিখতে আমাদের লাগবে। হ্যালো
Yes, sir.
শিশির,
Update.
গুড
Hello,
ইভিনিং।
Shishir.
Good evening, sir. Good evening, ma'am.
Good evening, Shishir.
Good evening, ma'am.
I think it's 8 p.m. We can start.
Now, our timing is 8:30, no? Kaushik? কৌশিক বলছিস তো?
I think it was Kaushik.
কৌশিক
It is 8 to 9:30, so we can start.
Okay. It is already few minutes past 8. We can start, huh? অভিলাষ তাহলে লাইভ করে দাও।
Yes, sir. YouTube
আচ্ছা,
live we have already kept.
কৌশিক কিন্তু নেই তো, দিনেশ আসেনি বোধহয় এখনো, নাকি? সুদীপ, দিনেশ কাউকেই তো দেখতে পাচ্ছি না। So what to do, Kaushik? Neither Dinesh nor Sudeep is there.
Rajiv Sharma is telling that without identical number, anybody can log in. Any quarter also can log in. Oh, দিয়েছে নিজের US country US দিয়েছে ঢুকে গেছে। এটা একটা ফল্ট আছে। Nobody can help it. আমারটা ইয়ে করা আছে। Let me leave it, come back. Yeah, I can't see anybody.
কৌশিক, কৌশিক, বল। আরে কি করে
হ্যালো,
Hello, Sudhir.
অডিবল?
Yes.
ঠিক আছে। অ্যাকচুয়ালি 8:30 আর 8:15-র মধ্যে কনফিউশন হয়েছে, ওই জন্য সব 8:15-তে জগ ইন করবে। আমি যতদূর জানি মনোজ সিং আমাকে লিখেছে 8:15 জয়েন করছি, নন্দকুমারও তাই লিখেছে 8:15 জয়েন করছি।
ঠিক আছে, এবার এই পরে পরে এই ব্যাপারটা শর্ট আউট করে দিস আর কি, এটা যেন না হ্যাঁ।
যাই হোক, যা হয়েছে হয়েছে।
এবার 8:15 তো বাজে, এখনই জয়েন করবে
সুজিত
সবাই।
জয়েন করে গেছে,
হুম।
সৌরভ আর
এভরিবডি, আমাকে দেখা যাচ্ছে?
হ্যাঁ
হ্যাঁ, তোমাকে
দেখুন,
না, তোমাকে দেখা যাচ্ছে না, তুমি মেঘনাদ
দেখা
হয়ে
যাচ্ছে
আছো। না,
না, ভিডিও তো করা আছে অন, এই না কেন?
তুমি আর সুব্রাদি আলাদা ঘরে তো, নাহলে এইকো হবে কিন্তু।
তো
No,
দেখে কি,
আলাদা আলাদা।
দেখে কি
ঠিক
মনে
আছে,
হচ্ছে, দেখি তো তোর ক্লিনিক্যাল আই
নিয়ে
দেখি
আসছে না
তোর।
কেন?
এইবার ঠিক আছে, এবার আছে আছে, মনে হচ্ছে আলাদাই আছে। আচ্ছা, দিনেশ দাকে মারলাম কেন? দাও আমি ইয়েকে মারি।
শুধু
তাহলে
আলাদা,
আমি আমি লগ
আলাদা
আউট করে আবার লগ ইন করছি তো।
আলাদা ঘরে না, শুধু আলাদা ফ্লোরে।
ব্যাকগ্রাউন্ড আলাদা পুরো দেখো।
তুই একটু ফোন মার, ওটা মনোজ সিংকে।
ওটাই মারছি, এটাই মারছি।
হ্যাঁ, নন্দকুমার গোপীনাথকে ওদের ফোন মার।
আমাকে মনোজ সিং ফার্স্ট স্পিকার, তাকে মারি আগে।
হ্যাঁ হ্যাঁ, তুই মনোজ সিংকে মার, আমি নন্দকুমার গোপীনাথকে ফোন মারছি।
ঠিক আছে। হ্যাঁ স্যার, ইউ ক্যান জয়েন স্যার, ইউ ক্যান জয়েন লিস্ট লিস্ট।
Good evening, sir.
विश्वनाथ has joined।
Yeah,
अच्छा,
good evening, sir. Yes.
हाँ, only सौरभ is left। मैं सौरभ को फोन मारता हूँ।
Saurav has also joined.
सौरभ has joined। सर is joining, मनोज सिंह से बात हुआ है, अभी
Sir,
join
I am already there, sir. Good evening. Good evening, ma'am.
सौरभ
Good
is
evening,
there।
sir.
Ah,
Okay,
good
okay,
evening.
Yeah,
Saurav,
I
good
am
evening.
there for last 10 minutes, sir.
okay, okay, सौरभ, थैंक यू। সুব্রতি দেখো তো মনোজ সিং জয়েন করেছি কিনা, বললো আমি করছি, এক্ষুনি করছি বললো।
আমার ভিডিও আসছে না কিছুতেই।
কার?
আমার
দিনেশ দা বলছে।
দিনেশ,
আমার ভিডিও?
আমার
না
আমার
না,
আমার
তোমার আসছে,
ও
দিনেশ
তাই
দাকে
বলো।
দেখা যাচ্ছে না।
কেন ভিডিও আসছে না আমি দেখছি।
তুমি একবার লগ আউট করে লগ ইন করো।
তাও করলাম একবার, তো আবার করছে।
ওয়াইফাই তে কানেক্টেড নেই দিনেশ দা?
সন্দীপ বন্ধুদের সঙ্গে কথা হলো নন্দকুমারের সঙ্গে? सर देयर इज अ लिंक आई सेंड यू, योर पर्सनल लिंक, आई एम सेंडिंग इट अगेन। आपको भेजा है मैंने, अपने पर्सनल लिंक व्हाट्सएप पर भी भेजा है, इसमें भी भेजा है। अच्छा मैं दे रहा हूँ, अब दोबारा दे रहा हूँ। दाঁড়াও, लिंक হারিয়ে ফেলেছি, लिंक पर भेजते दो।
আচ্ছা,
सुबह भी भेजा मैंने उसको।
ইউটিউবে কিন্তু অলরেডি ইট ইজ অ্যাক্টিভ, সো সুদীপ বেশি কথা বলার দরকার নেই, ঠিক আছে? Ah, friend, Gopi, good evening. Good evening. Are you joining? Okay, you have joined, huh? So, in case Dr. Manas Singh is late, can you take the first lecture?
দাদা মনোজ সিং
Sure.
লাগে ইয়ে আরে পাঠিয়ে দিয়েছি ওকে আমি ওর লিঙ্ক খুঁজে বেড়াচ্ছিল আমি পাঠিয়ে দিয়েছি পাঠানো হয়েছে আবার মেলেও পাঠিয়ে দিচ্ছি ওকে 1 মিনিট ওয়েট করে দিচ্ছি আমি শেয়ার করে দিচ্ছি
Dr. Nandkumar, you can just share your presentation and just check it whether it is.
কতক্ষণ চেক করো
Shudip, in the meantime, if Dr. Manas Singh is late, let us start with Dr. Nandkumar.
লেট হবে না তুমি 8:30 বলেছি তো যে কনফিউশন অফ টাইমিং হবে লেট ইট স্টার্ট না ওকে
Right.
Am I audible?
Yeah, you are
Yes, sir.
audible. You are audible. You are audible,
The-
Nand.
Screen is visible also.
Yeah, screen is also visible and it is moving also. So let us start. Okay.
দাঁড়া 1 মিনিট
আমার ভিডিও নিয়ে আমি এমনি বলবো তাহলে, হ্যাঁ? আমার ভিডিও আসছে না আনফরচুনেটলি।
No problem. तुम एमनी बोलो.
आपको मैंने मेल पर भी भेजा व्हाट्सएप पर भी भेजा तो ज्वाइन कर जाइए सर ज्वाइन कर हाँ अब ज्वाइन कर गया ओके अच्छा সন্দীপন দা মনোজ সিং জয়েন করে গেছে বলছি তো
হ্যাঁ জয়েন করেছে তুই দেখতে পাচ্ছিস না তোর
না
চোখের
আমার
সামনে
এখানে
তো।
সব খুলছে না দেখছি দাঁড়াও ঠিক আছে ওকে সো উই
Let us start.
so
Hmm.
we are starting the second episode of third episode of Dharmadhyan after 2 episodes of leprosy and STI. So may I invite our IDBL West Bengal President, Dr. Sandipan Dhar, to deliver a few words on Dharmadhyan and what is the motto of IDBL West Bengal for doing it.
Thank you, Sudeep, and good evening, esteemed colleagues and friends. Welcome to today's webinar. IADBL West Bengal has a very rich heritage and history, starting from the first president of IADBL National, Dr. B.N. Banerjee, was from this city. The logo of IADBL, which is so precious to all of us, was designed by Dr. A.C. Mondol from this city only. The journal, Indian Journal of Dermatology, was published from IADBL West Bengal, which was the first dermatology journal in not only India, in entire Asia, first PubMed Index Dermatology Journal. And this is the first dermatology journal in India which went to web. There are many more things. The national conferences, Dema regional conferences and state conferences were named from IADBL National Conference to DermaCon, DermaZone, and QTCon by my predecessor, illustrious President Dr. Kaushik Lahiri. He was very instrumental in this. So, keeping in pace with this tradition of innovative ideas and paving the new pathways, this year IADBL West Bengal has taken up a couple of new projects. So, Dharmadhyan is one of our prime projects this year. Every month, there will be a discussion, a threadbare discussion on a topic by the national experts. This is the brainchild of our academy chairperson, Dr. Sudeep Das. And as he has mentioned, this is the third one in a row. Today, we are going to discuss about dermatopathology. So with these few words, I welcome once again all. I hand over the platform to our President-elect, Dr. Dinesh Havelia, to welcome our guests. Over to you, Dr. Dinesh Havelia.
Thank you, Dr. Sandipan. It's my proud privilege to welcome our guests from all over the country to listen to experience such an enlightening experience on dermatopathology, which is probably a very neglected topic. I feel that dermatology is not complete without dermatopathology. So unless we have a grip on this subject, we cannot be called as complete dermatologists. And we are really happy to have Dr. Nand Kishore, Dr. Manoj Kumar Singh, Dr. Saurabh Singh, Dr. Vishwanath Behra, and our own Dr. Shubhra Dhar and Dr. Shishir Das today to enlighten us on such a neglected topic, dermatopathology. And I am sure that everyone will be benefited by our flagship activity of our IDBL West Bengal branch on its third episode on dermatopathology, a brainchild of Dr. Sudeep Das. So over to Dr. Sudeep Das to introduce the speakers.
Thank you, Dinesh da. Now, without wasting much time, I would like to firstly introduce two very erudite and senior dermatopathologists today, Dr. Manoj Kumar Singh, my teacher, who has been instrumental in teaching us dermatopathology from our AIMS days, with the way residency days. And nobody needs introduction in India, at least, of Dr. Manoj Singh. He was one of the pioneer dermatopathologists. We also have Dr. Nand Kumar Gopinath, who is one of the most erudite dermatopathologists that the country has among the things. So today we'll having two important lectures, demystifying granulomas from Dr. Singh, and then Dr. Nand Kumar Gopinath will speak on unraveling the basal membrane for the basal membrane. Then it will be a moderation of a case-based moderate discussion by Dr. Shubhra Dhar, who is now the head of wisdom dermatopathology, and also she was first previously SRL of the head of SRL Ranbaxy, and she is a noted dermatopathologist in the state of West Bengal and also a member of the DCI and an active member of all the dermatopathology sessions here. We have Dr. Vishwanath Behra, who is additional professor of AIMS Bhubaneswar, Dr. Saurabh Singh, professor AIMS Jodhpur, Shishir Das, who is a faculty in Malda Medical College. So we have all this faculty who are doing dermatopathology in their own hands, and they are practicing dermatopathology. And so we hope to have a wonderful evening from them. So the first lecture I would expect from Dr. Manoj Singh, demystifying granulomas. Sir, you can start and share your screen.
Hi. Okay, so how do I switch the screen to you?
Screen share, there is a share screen option, the green button.
Where there we are. Okay.
Sir, at the bottom, if you
I press the green button, all right, but I'm trying to just find the
share screen option is there, sir.
in green color.
no, I press that. I'm now trying
After
to
the chat, green button, share screen.
Is that coming up now?
No, sir, your picture is coming up.
Oh dear.
Sir, if you move the cursor on your screen, then you'll see the share screen button.
No, I've seen the share screen button and I'm pressing it, but unfortunately,
Sir, will I start with Dr. Gopinath first, and then in the meantime,
please do.
So-
What I'll do is maybe I'll log out and log
and you
back.
can, sir, you can one more thing you can mail it to me, or I'll send it to the person to shut up from their end.
So
If you want-
you can start with Dr. Gupta.
So, Dr. Sir, Nand Kumar sir, I think you start the session, then we will start with Dr. Manoj Singh, the second lecture.
Am I audible?
Yes, sir.
Yes, Dr.
Perfectly.
Gupta.
Perfectly. It's a full screen mode. Okay.
Has it come? The full screen has come.
Yeah.
Yes, sir.
Yes, it has come.
Good evening. Good evening to all. My special thanks to Dr. Sandeepinder and Dr. Sudeep Das for inviting me for this unique Zoom meeting, an academic endeavor of West Bengal IADBL. I congratulate the members and the organizers for doing this wonderful job. My lecture today is on basement membrane zone. It is a very complex and dry subject. I don't know whether on a Sunday evening people will be really enthusiastic about going through such a theoretical topic, but this is something which is essential in understanding a whole lot of dermatological diseases. So we have no option but to learn about basement membrane zone and familiarize with the numerous terms of molecules that form this complex structure. We know that skin is a highly specialized and dynamic structure. Its beauty is masked only by its wondrous complexity. And its integrity is maintained by a specialized structural complex that anchors the overlying epidermis to the dermal matrix below, known initially as basal cell layer or basement membrane, but now, because of better understanding, we use the term basement membrane zone. This structure is anatomically distinct from the overlying epidermis and the underlying dermis, but functionally is interrelated. So, in a nutshell, basement membrane zone is the area of adherence between the basal layer of the epidermal keratinocytes and the dermis just beneath that. That is the papillary dermis. In the routine hematoxylin and eosin stained sections, we will not be able to make out this basement membrane zone. We will be identifying the basal cells or the lower portion of the epidermis and then the papillary dermis. But the basement membrane zone as such will not be visible in the routine hematoxylin and eosin stained sections. But when you use a special histochemical stain like PAS or PAS, which stains the glycogen material, this basement membrane zone gets beautifully illustrated, as we can see on the right-hand side of my screen. 4 structures essentially constitutes the basement membrane zone. That is the basal keratinocyte layer, lamina lucida, we'll come to that in a minute, lamina densa, and the sublamina densa. The sublamina densa is what is constituted by the superficial papillary dermis. To make it more complex, there are 13 distinct molecules with important functions within the basement membrane zone that contributes to the integrity and the varied functions that this zone contributes to the skin. This is a diagrammatic representation of the basement membrane zone with the overlying basal cell. We have the numerous structures about which I shall be mentioning very briefly in the next few minutes. We have the basal cell, the hemidesmosome, then we have the anchoring fibrils and the dermal collagen looping through the anchoring fibrils. And there are several other molecules which also contributes to this zone. So this is the basal cell, the hemidesmosome attaching to the basement membrane zone or the lamina lucida, and beneath the lamina lucida we have the lamina densa. And the lamina densa, the lamina lucida anchors to the lamina densa through the anchoring fibrils through which the dermal collagen, the upper part of the dermal collagen, that is type 1 and type 2, loops through. As I said, the ideal name for this area would be basement membrane zone rather than basal cell layer or basement membrane, because this is not simply a membrane, but it is a very complex structure. This is the overlying keratinocytes, this is the dermis beneath, and this is the 3D image of the basement membrane zone. The basal keratinocyte is anchored to the basal lamina via the intermediate filaments and hemidesmosomes. And the molecules within the basal lamina connect the basal keratinocyte to the basal lamina. This is the hemidesmosome, and this is the keratin intermediate filaments, which forms the cytoskeleton of the keratinocyte. The intermediate filaments attach onto the electron-dense rivet-like plaque. This is the electron-dense rivet-like plaque located at the lower portion of the basal keratinocyte, studded along the ventral surface of the basal keratinocyte. This is the hemidesmosome. So this is the keratin intermediate filaments forming the cytoskeleton, and this is the hemidesmosome. What is the function of these intermediate filaments? Structural and mechanical cellular integrity, organization of the cytoplasmic structure, intracellular signaling, and regulation of transcription. It offers the structural support, movement of the cell above the basal cell layer, intracellular transport of substances and molecules, and anchors the cell to the basement membrane. There are 6 types of intermediate filaments. First is the acidic, followed by the basic. Then we have the desmin, the glial fibrillary acidic protein, which is prominently seen within the neural system. Then type 4 intermediate filaments, type 5 the laminins, and type 6 the nestin. Similarly, we have 5 types of hemidesmosomes, which is important in our discussion and understanding the diseases caused by defects in this area. There is a bullous pemphigoid antigen, plectins, integrins, collagen 17, also known as bullous pemphigoid antigen 2, and CD151, a cluster differentiation 151. Bullous pemphigoid antigen 1 was one of the first hemidesmosomal components identified associated with bullous pemphigoid. And people were very excited in recognizing this as the antigen involved in the causation of bullous pemphigoid. But better understanding prevails now, as I shall just now mention. The molecule is located inside the basal keratinocyte, as you can see in this diagram. It is localized at the inner plaque of the hemidesmosome. So that is bullous pemphigoid antigen 1. Then we have the plectin. This large protein interacts with all the cytoskeletal proteins like microfilaments, intermediate filaments, and microtubules. And this is also located within the basal keratinocytes. The integrins links the cytoskeleton to the extracellular matrix. It serves as the regulator of basement membrane development as it is present in the pre-hemidesmosomal stage. That is the development stage of the skin. Because of the lack of time, I will not be going into the embryology of skin at all. Collagen 17 is found in the basal keratinocyte. Again, the lamina lucida and lamina densa layers of the basement membrane zone also host this collagen 17. And our understanding now is that it is associated with linear IgA bullous dermatosis. Cluster differentiation 151 found only within the basal cell layer along the dermal epidermal interface. This is one of the earliest molecules seen in the early embryonic development of the skin. One should be very clear in mind that lamina lucida is an artifact of processing. Images of basement membrane zone that demonstrate a lamina lucida were produced by older electron microscopic techniques which use dehydration for tissue fixation. So it is important to remember that lamina lucida is not present in living basement membrane. But even now, when dehydration techniques are used for tissue fixation, this can be seen in certain anatomical regions. Lamina densa is a very important layer located just beneath the so-called lamina lucida. This is an electron-dense zone, and important molecules within the lamina densa include the collagen 4, integrins, laminins, nidogen, and perlecan. Collagen 4 is synthesized in the rough endoplasmic reticulum and secreted via Golgi apparatus into the basement membrane zone. This is the diagrammatic representation for easy understanding of the collagen 4 and laminins located at the lamina densa layer. So this is the hemidesmosome. Just above that, one can see portion of the basal keratinocyte, and this is the lamina densa layer. And this is the sublamina densa layer. At the lamina densa layer, the hemidesmosomes attach to the underlying connective tissue matrix of the papillary dermis through transmembrane proteins such as the integrins that one can make out in the diagram. Other molecules found within the lamina densa layer of the basement membrane zone include nidogens and perlecans, playing a supportive role in the stabilization of the basement membrane. I shall be mentioning 2 words about these 2 structures subsequently. Now, the sublamina densa layer, or the papillary dermis, as it is commonly known, is located just directly beneath the lamina densa, and are composed of bundles of anchoring fibrils composed of collagen 7. Collagen 1 and 2 are the major components of the superficial dermis. So the sublaminar densa has contribution both from the basement membrane zone by way of the collagen 7 and that of the papillary dermis, that is collagen 1 and 3. The collagen 7, as I said, is secreted both by the keratinocytes as well as the dermal fibroblasts. What is the function of this basement membrane zone? The initial understanding was that it contributes to the adherence, architectural integrity, and protection against shear forces. But now we know that it has got additional functions like permeability barrier function. It's a template for wound healing, signal transduction, and very importantly, as we understand now, it's a regulator of cancer progression. The intermediate filaments, or the cytoskeleton of the basal keratinocyte, a lot of studies have undergone regarding these structures now, and there are a number of disorders associated with the keratins and other types of intermediate filaments. And I would just like to mention that cytokeratins 8, 18, and 19 have now been found to be important in the early detection of epithelial cell carcinoma recurrence. So a patient who has been diagnosed to have an epithelial cell carcinoma, who has undergone complete treatment and is on follow-up, one can do this cytokeratin 8, 18, and 19 for any evidence of recurrence. Bullous pemphigoid antigen, I have already demonstrated its location at the basal keratinocyte. It was recognized as being associated with the bullous pemphigoid, but now as well as paraneoplastic pemphigus. But recent studies have revealed that collagen 17 and not bullous pemphigoid antigen 1 per se shows the T and B reactivity in patients with bullous pemphigoid, indicating that perhaps collagen 17 may in fact be the primary antigen in bullous pemphigoid, and bullous pemphigoid antigen 1 may be a contributing factor to the collagen 17. Plectin is a large molecule that imparts a great deal of stability to the hemidesmosome. It is located within the basal keratinocyte. A defect in plectin is associated with epidermolysis bullosa simplex with muscular dystrophy, epidermolysis bullosa simplex with pyloric atresia, and the OGNA variant of epidermolysis bullosa simplex. Integrins are necessary for maintaining epidermal hemostatic functions such as adhesion, proliferation, and differentiation. Integrin gene mutations are associated with several diseases such as junctional epidermolysis bullosa with pyloric atresia and even in papillosquamous conditions like psoriasis. Collagen 17 has a predominantly structural function within the basement membrane zone. This is the diagrammatic representation of the location of collagen 17. As a major antigen associated with bullous pemphigoid, as we understand now, its structural significance cannot be understated. And a mutation or cleavage at collagen 17 results in the disease linear IgA bullous dermatosis. So this, in addition to the bullous pemphigoid, it contributes in the pathogenesis of linear IgA bullous dermatosis. Cluster differentiation 151 expression has been associated with Merkel cell carcinoma, ductal breast carcinoma, and adenocarcinoma of the prostate, as well as hepatocellular carcinoma. It is now found that CD151 levels correlate with overall poorer survival outcomes in breast and prostate malignancy and even in hepatocellular carcinoma. Laminins are the glue that binds structures within the basement membrane zone. So important is the structural function of laminin that embryogenesis cannot occur in the absence of laminin. So if we do not have laminin, the rest of the basement membrane zone will go dysfunctional. Perlecan confers an overall negative charge to the basement membrane, which allows this molecule to serve its primary function as a permeability barrier within the basement membrane zone. This is the location of the perlecan, just in the lamina densa zone. Collagen 4's primary role in the basement membrane is structural and is also associated with angiogenesis, tissue remodeling, and cancer progression. There are many genetic diseases attributed to collagen 4, such as Goodpasture syndrome, Alport syndrome, and diffuse esophageal leiomyomatosis. Collagen 7 is predominantly localized to the epidermal basement membrane zone within the lamina densa and sublamina densa, this area, and is derived primarily from epidermal keratinocytes. That is what I said just a while ago. It provides structural support as well as stability to the epidermal basement zone. This is just a textbook photograph of the different diseases that occurs at the basement membrane zone. And this is a better list, easily understandable. Epidermolysis bullosa, mucous membrane pemphigoid, bullous pemphigoid, junctional epidermolysis bullosa, pemphigoid gestations, lichen planus pemphigoids, linear IgA disease, and epidermolysis bullosa acquisita. This list is not complete. I just picked out the important ones and the antigens associated with these conditions. So in conclusion, the basement membrane zone, in addition to contributing to the adherence, architectural integrity, protection against shear forces, has got an important role to play with regards to the permeability barrier of the epidermis from the dermis. It's a template for wound healing and plays an important role in signal transduction and a very important role as a regulator of cancer progression. And we can understand the pathogenesis of many cancers by understanding the importance of cytoskeleton and intermediate filaments as of now. Thank you very much. Wisdom lies in knowing when to stop, and I hope I have stopped in the time allotted to me. Thank you once again very much for your kind attention. Thank you very much.
Thank you, Dr. Nandkumar, for a erudite lecture. So may I invite now Dr. Manoj Singh to deliver his talk. I had already requested sir to share his Google Drive link to Subhradi, who will share it if it's not from his end. And sir also wants questions from the audience during his talk.
Screen sharing has failed to start. That is the problem.
So can you see the screen from my end?
Are you projecting now?
Yes.
Granulomas of the skin is coming up from you,
Yeah,
Yes.
it's visible.
or is this mine?
It is your.
Mine.
Granular monosing empty.
No, it is not yours. I am projecting it.
No, this is mine.
No, it is sir slide that Subrata is
Sir,
projecting.
slide that I am projecting.
Please see. This is not moving with me, is it?
Just a second. Just a second. Let me start
Sir, it will
slide.
move with Subrata only. Subrata will change every time.
Okay, fine. That's okay.
So
Subrata
this is
will
the first slide. Sir, you
Subra?
can start speaking. Sir, you can start speaking. This is the first
Subrata
slide.
full screen হয়নি Subrata make it full screen.
I have made it full screen.
দেখা যাচ্ছে না দেখছি
So it's
Sir,
not
it is full screen. It's full screen, ma'am.
okay.
Oh,
Thank you.
wow. I am not seeing full screen, man.
I am also not seeing क्यों नहीं पता नहीं मेरे को
There's some
There's the
problem.
top zoom link. You can maybe. There's
What
a
about
small
that?
tab on. There is a small tab on the screen which shows screen share. It has two options, one from Manoj sir and one from Subramanian.
So I'll escape. I'll exit this.
Yeah, please, just for a minute.
I'm stopping share. I think this is sir's screen that we are looking at.
Stop videos, new share, pause share, annotate,
Sir, we can see your screen, sir. You just have to open your that my PPT too.
You're seeing this?
Yes, we are seeing it.
Oh,
Yes,
fine.
yes, sir. You just have to open it.
You can see this now, Shubhra?
Yes, I can.
Oh, lovely. Lovely. So it has happened. I'm not seeing anything else, but I'll carry on with this, okay?
Sir, you have to make it full screen, I think.
Yeah, I've just made it full screen. अभी
सर
आ रहा
यहाँ नहीं खुला नहीं है अभी तक. Just granulomas of the skin छोटा होके आ रहा है.
ये आ गया granuloma?
Manoj sir, what I will suggest you that let Subrata share the screen and you speak on the important. She will be changing the
Okay.
slides.
It's fine.
Subrata,
We can do that.
who starts?
স্যার
Then,
পালসান
sir,
থেকে যে
sir, you
আছেন
will have
উনি
to.
রিমোট অ্যাক্সেস করে ওটা স্যারেরটা অন করে দিই
বুঝলাম না
পালসান থেকে যে হোস্ট আছেন উনি স্যারেরটা রিমোট অ্যাক্সেস করে ওনার কম্পিউটারটা অ্যাক্সেস করে দিক ওটা
তাহলে বলে দে পালসিয়াকে অভিজিৎকে বলে দে অভিজিৎ বোধহয় আছে
অভিলাষকে
অভিলাষ
উনি শুনতে পাচ্ছেন স্যারেরটা রিমোট অ্যাক্সেস করে ওটা অন করে দিতে হবে
Sir, for that we have to have a different software. I think it will take time. It's better if Madam can share.
That's okay.
Otherwise it will take
I'm comfortable, Shubhra. Can you
Oh,
please?
sir, you have to stop sharing. Okay, sir. Can you see?
Have I stopped sharing now?
Yeah, it is coming
You have-
properly.
Okay, Shubhra,
Now
let's go.
Yes,
I
yes.
am sharing now.
Yes, it is
Fine.
seen, very clearly seen now.
Please,
Yes.
Okay,
please.
I am
do
proceeding
right
with the first slide.
here. Yes, ma'am. And good evening to everybody. The topic I am covering today is granulomas of the skin. And this granuloma, as you guys know, it's a very funny thing. There are at the moment 96 participants here. And if I was to ask you, what is a granuloma or define a granuloma, I'm sure we would come up with, at least 96 definitions. So this is because granuloma is such a common thing. It manifests to us in so many diseases and conditions and so on and so forth, that it's very difficult to actually precisely pin down and the definition. So the textbooks of pathology, the basic textbooks, define granuloma in a very simple fashion. And this will encompass a lot of the definitions which you might, come up with. So a granuloma is an organized collection of activated histiocytes. Full stop. That's it. A granuloma is an organized collection of activated histiocytes. With or without giant cells, with or without necrosis, with and without eosinophils, with and without acute inflammation, whatever. So, our concept that a granuloma should have, some kind of giant cell, necrosis, this, that, not compulsory. A granuloma is an activated collection, is an organized collection of activated macrophages. Next, please. And here, of course, you see the epithelioid cell. Next, please, Shubhra.
Sir, I have already done the next one.
Next. Granulomas, generally speaking, are of two types: infectious and non-infectious. Infectious are many of the ones which we are familiar with, TB, leprosy, fungi, and so on and so forth. Non-infectious are, foreign body granulomas and some diseases, autoimmune diseases, which may present with the granulomas. Next. And this is a very important stain, which frequently is used to distinguish an infectious granuloma from a non-infectious granuloma. As you can make out here, this is a reticulin stain. And as you can make out here, each one of these is a granuloma. In the first one, you see that there is a lot of reticulin present inside the granuloma. You can see that. And in the next one, you see that the outside rim is nicely positive, but the content of the granuloma, where actually the granuloma is present, is very low in reticulin. And this is the difference between an infectious granuloma, like leprosy, TB, and so on and so forth, in which the reticulin gets eaten up by the inflammatory process, and certain other conditions. The prime example of those conditions is, of course, as you know, sarcoidosis. So that's a great differential of skin granulomas, and between TB, tuberculosis, sarcoid, a reticulin stain at times may be of help. Thanks. Next, please. So TB of the skin, of course, as you know, caused by M. tuberculosis, which is a small rod containing a cell wall which is rich in lipids, which is an important part of the pathogenesis, and a very long replication period. Next, please. The rich in lipid, next, please. Rich in lipid material decides that it is more resistant to the body's immune mechanism than a lot of other organisms. And that is part of the pathogenesis and the manifestations of mycobacterial diseases. Again, the great ones there being tuberculosis and leprosy. Tuberculosis or tuberculodermas are primary, secondary, and the hypersensitivity reactions. Now, what is primary tuberculosis? Next, please. Primary tuberculosis is when the infection starts or occurs in the skin, as opposed to a lot of other patients and so on, in which it occurs in the lung. And secondary tuberculosis is actually the one which we are more familiar with. In primary tuberculosis, the body's immunity to the organism occurs, and that person is henceforth immune to varying extents to tuberculosis. And then when there is a secondary infection, which could be endogenous through the circulation, or also commonly exogenous, then you have the classic manifestations of cutaneous tuberculosis, secondary tuberculosis, and the most important one, of course, as you know, is lupus vulgaris. Lupus vulgaris is nothing but, next please, and inflammation in the upper dermis, could be in the throughout the dermis, with reactive changes in the epidermis. And you can make out here, I mean, actually in this magnification, you can see that there is a very dense band-like inflammation. But in this, you can make out in between that there are a few pinkish structures. Those are the granulomas. Next, please. And there's a granuloma, higher power. Next, please. And again, you are able to make out here that there is a granuloma. This granuloma happens to contain epithelioid cells. Next, please. Epithelioid cells and giant cells. And this is the other manifestation of secondary tuberculosis of the skin, which is tuberculosis varicose cutis. And of course, we define them separately, and they are distinct, usually distinct clinically. But a TVC is actually nothing but lupus vulgaris, which has been going on for some time, and it manifests in a clinical scenario and a clinical presentation which is different from lupus vulgaris. And as you can make out here in the area of the buttock or on the heel, that this is a very large amount of hyperkeratosis. And the differential in tuberculosis varicose cutis, in some cases, it might be very, very clear, but in many cases, the differential of TVC actually is other disorders which cause this amount of reactive hyperkeratosis. It occurs, of course, in TB because TB is a very resistant organism, as I mentioned earlier. And the organism may continue for months or years to cause the infection wherever it is causing the infection. And the body's immune response keeps trying to overcome it. And all these are nothing but reactive changes. Next, please. And as you can make out here in a section, very difficult to actually cut a section because there is so much hyperkeratosis and acanthosis in that particular biopsy. You can make out here that there is a lot of hyperkeratosis, almost forming a cutaneous horn, and acanthosis, and a very large amount of inflammation in the upper dermis usually. And if you just see that area, it's quite similar to the lupus vulgaris, which we saw earlier. But the reactive changes are much more. And people have done a lot of work on, trying to study the immune mechanism in the two conditions, and saying that in this one, the immune mechanism is less, slower, the organism is, more prone to attack, and trying to work out the reason why lupus vulgaris is not as reactive, secondary reactive process as the TVC does. Not particularly fruitful, these studies. Next, please. And I'd just like to mention in the previous slide that when you see a biopsy, which may or may not be with a clinical diagnosis of TVC, because the clinician team might not be able to call it definitively as TVC, and they may just send you a biopsy with a list of differential diagnoses. In those conditions, the important thing is to study very carefully. If you see in multiple step sections, you may see a granuloma in one particular site. And if you see that granuloma in that particular site, then you start thinking of tuberculosis varicose cutis. Otherwise, the whole host of other hyperkeratotic and acanthotic disorders are also may also be part of the clinical differential. Next, please. The third condition which very commonly we see is scropholoderma. And scropholoderma is actually a superficial involvement of tuberculosis, which usually it's in a lymph node. So here, of course, we are seeing in an extremity, in a hand or a foot, in a hand actually. But scrophulloderma is very common in the axilla, the groin, and so on, where the lymph nodes are superficial. Scrophulloderma may also be associated with an underlying bone tuberculosis. But what happens in scrophulloderma is that there is an inflammation, tuberculous infection and inflammation deep down in the lymph node or in the bone or in the soft tissue, and the bursts through. Now, one issue I'd like to share with you, M. tuberculosis, as opposed to a lot of other organisms, is an obligate aerode. What does that mean? It means that M. tuberculosis grows much better when the surrounding oxygen is higher. Now, this is a thing which is of particularly important in lung tuberculosis in some aspects, but in skin also, in scrophulloderma. As you can imagine, if you remember back to your physiology, the PO2 in the venous and the arterial blood is so much. Coming in arterial blood, the PO2 is about 100. The venous PO2 is maybe, 70, 80 or something. But when you have something connecting with the outside air, the PO2 of the outside air is 140, right? So the organisms here in scrophulloderma, when there is a sinus forming, are actually at a relative growth advantage compared with organisms which are deeper down. So a scrophulloderma, the M. tuberculosis, has more chance to grow. And again, of course, lesser things that the immune reaction of the body is, kind of walled off because of, fibrosis and so on and so forth. So here, particularly, the organisms are more prone to grow faster. So scrophulloderma may become more of a problem than in other conditions. Next, please. Again, a dried out sinus of scrophulloderma at the neck. It may fibrose, it may, have a sinus remaining. It may have infection the way we saw in the earlier biopsy. Next, please. And in this one, you can make out in the axilla. And what does one see in the microscopy? Again, because it is connecting with the outside, the granulomatous picture, which you will see deeper down in the skin or in the lymph node, it will be potentiated by acute inflammation, because there is superadded infection of bacteria coming in from outside. There will also be, apart from the classic manifestations of a granuloma of the skin, there will be acute inflammation, there will be eosinophils. So there is a maxim that in tuberculosis, you do not see eosinophils. This is one of the exceptions. Next, please. And lichen scrophullosorum and many other conditions, clinical conditions, are defined by the lichen scrophullosorum and papillonecrotic tuberculin and so on and so forth. These are possibly manifestations of the hypersensitivity in the body to the tubercular protein. And the clinical presentation is quite characteristic in many of these. And the clinician may give us a biopsy that this is a classic condition. And at times, the histopathology may not support that classic condition, because, this is a very varied group of conditions clinically as well as microscopically. Next, please. And the other big disorder which causes granulomas of the skin is, of course, as you know, leprosy. Next, please. Can we go very fast, Shubhra? Yeah.
Yes.
Leprosy is defined as, this is something which you all are very, very familiar with, that the Ridley-Joplin classification defines leprosy into several groups by a combination of the clinical appearance, the bacterial load, and so on. And these groups vary from TT going on to BT, BB, BL, and LL. And of course, the one which concerns us is the tuberculoid leprosy. And in tuberculoid leprosy, again, next please. Clinically, tuberculoid leprosy caused by M. leprae, which is actually a little more sensitive than M. tuberculosis. So the disease manifestation is different in leprosy as in tuberculoid leprosy than it is in tuberculosis. And but of course, because the basic structure of the large amounts of glycolipid in the wall makes it much more resistant than other bacteria or organisms. It remains, a very chronic, slow-growing condition. This is, as you all would be able to recognize, the clinical features of tuberculoid leprosy. Next, please. And microscopically, we see a picture of granulomas. One thing which you may like to note is something which is suggestive, I would say, not diagnostic really. You can make out here that in the lower part, there is this, sleeve-like pattern, big sleeve-like pattern of granulomas and surrounding a lot of inflammatory cells, which are actually lymphocytes. And this sinuous kind of sleeve-like pattern is quite suggestive of tuberculoid leprosy. And when you see a biopsy in which you may or may not have a clinical diagnosis, and you see this kind of a picture, you should, entertain the possibility of a tuberculoid leprosy. As you can make out here, that the picture in the lower dermis is fairly classic. In the upper dermis, and if you had only that one, there are granulomas there, but if you had only that one, then, you might be in difficulty to try and categorize this. Next, please. And of course, as you can see here, it's, a fairly classic granuloma with a lot of lymphocytes. The lymphocytes represent the immune process in leprosy, in tuberculoid leprosy. Next, please. And as you can see, this kind of a patchy involvement here again, you can make out that in that upper one, that there is a kind of a sleeve-like process. Epithelioid cells are there, Langerhans cells are there, and a lot of lymphocytes are there. Next, please. At times, the middle zone of the Ridley-Joplin classification, which is borderline leprosy. Now, borderline leprosy, you would remember, of course, includes both BT, which is very which may be very similar to the polar tuberculoid leprosy, and even BB. So there are situations, there are cases which, again, you would all be familiar with, where you have a fairly classic granuloma formation, and in association with that granuloma formation, you may have acid-fast bacilli also. And when you have that kind of a picture, you are, likely to be looking at the borderline zone. Next, please. Now, this we'll go very quickly over, but fungi of various types. I'm not going to, differentiate these. That actually needs a different lecture on fungal infections of the skin. But fungi are, superficial mycosis, which we'll not consider here. These are the tinea and so on and so forth. Mucocutaneous and subcutaneous mycosis, and the deep mycosis. Next, please. Next, please. Now, this we'll go very quickly over, that localized primary infections of subcutaneous tissue by fungi. So there is an immune response in this, as there is in tuberculosis and so on and so forth. And one of the distinct features of this, apart from granulomas of various types and giant cells and so on, is a lot of eosinophils. So when you see eosinophils, also you should keep a mind open that this may be fungal infection. And the other, of course, I've got a lot of slides here. Shubhraji, can we please just go quickly over these? Again, and just a minute, please. Histoplasmosis and cryptococcosis. Next, please. Are small fungi, spore-like fungi, which may have a very, very hidden kind of manifestation. Clinically, you may be able to diagnose it. Morphologically, next, please. Morphologically, it may give you trouble. We'll just see a few pictures of that. Again, we are going back to lupus vulgaris in that slide. And next, please. And this slide, next, please, of a fungal infection, to show you that clinically, some of these mycosis may look quite like tuberculosis varicose cutis. And here you can make out that using the special stains for fungi, which are PAS and silvermethanamine, what is not so apparent, even though you can make it out in the HND, they become obvious in the special stains. Next, please. Next, please. And these fungi are recognizable by their morphology of the individual fungus, whether it's forming, small round bodies, or you have filaments of various types, as you can make out here. Next, please. Next, please. This is cryptococcosis. Next, please. And one very nice thing which you can try with the cryptococcosis. I'm sorry, I have not got that picture here. But in cryptococcosis and some of these small fungi, if you polarize, you are able to make out, distinctly small specks inside the giant cells and the granulomas. And polarizing is something which is of help at times. Now here, what do we have here? We see that in the middle of that giant cell, there is that brown pigmented material, right? If you see the higher power, next. That next slide, please. This is chromoblastomycosis. And again, these chromo and many of the fungi are actually implantation infections. So they are common in the northeastern parts of our country, where, a small thorn or a branch may cause a penetrating injury, and there may be an infection. Next, please. I think we'll just skip this. Next, please. One curiosity. Those of you who are pathologists would be very familiar with this picture, right?
Yes.
This is rhinosporidiosis.
Sporangia.
A very common condition in the nose and the nasal cavities. And if a pathologist sees this, then they would immediately recognize these sporangia. Not so much for a dermatologist, but just to point out to you that rhinosporidiosis may also occur in the skin. And obviously, it will be common in the area surrounding the face and the nose and so on and so forth. But we have actually a very classic case, which was in the pararectal region. And how it reached there, of course, there was just a single case, but rhinosporidiosis also may occur. And these are the characteristic features of a rhinosporidiosis. Next, please. Again, a stain of the same. Now, the other big group is the mycetomas. As you all would be very familiar, eumycetoma and actinomycetoma. Eumycetoma is a true fungus. Actinomycetoma is caused by an actinomyces, and it's not a true fungus, but the clinical manifestation and presentation may be quite similar. And therefore, distinction is necessary to guide the treatment. Next, please. Next, next, next. So you can make out here that, when you do a biopsy, you may or may not be able to see the organisms. You will see large abscesses, acute and chronic mixed granulomas, fibrosis, as you saw in that clinical feature. There are times when actually, even though with the current highly advanced antifungal treatments available, the treatment may or may not be successful. And an amputation at one time was considered the treatment of choice, actually. Less so with the advanced chemotherapy regimes are available, but still, if you have a large amount of functional impairment in the limb, an amputation may be thought of. Next. Classic picture with a special stain. You can make out here that the entire grain, this is the colony of the organism, and you may be able to make out especially in the special stain, but also in the HND. If you are seeing septate hyphae, it's a eumycetoma. If you are seeing fine fibrillar filaments, it's more likely to be an actinomycetoma. Stains and so on can be tried. Stains are of help. And next, please. These colonies are present inside abscesses. And one thing which if you have a patient admitted with you or under your care, this, as you saw in the clinical picture, are actually, multiple discharging sinuses particularly in the peripheral limb, in the foot, in the leg, in the hand, and so on and so forth. And the biopsy, because, the entire foot is involved, and the biopsy which you do is actually, a punch biopsy, that may or may not yield the grains. And one very nice technique is that you clean that particular area and you put a white gauze dressing on top, leave it for 24 hours. And there are times when the grain may discharge and be identified on the white gauze dressing. Especially useful, of course, in-house patients and admitted patients and so on. But it's something which can be tried. And this is the appearance of a grain which has come out and has been processed separately. Next, please. I think that's all here. Yeah, you can make out the C of acute inflammation and the organism inside it. Next, please. Chromomycosis, as we've seen earlier. Very nice picture of looking like copper pennies. Maybe more than one, maybe single, maybe scattered. Usually, because again, it's a resistant organism, you may see it inside the giant cells, and you may see it also scattered around the giant cells, and a classic granuloma with acute inflammation in it. Next, please. Next, please. Next. Not important. Next, please. Next, please.
So we're finished. Thank you.
Go one more. This
Thank
again,
you, Sayed.
that one. So what I have actually not included here is foreign body granulomas, which are by implantation. So if you have a thorn or a glass or so on and so forth injury, then that again may evoke a foreign body type of granuloma. And again, in many of these granulomas, polarizing the section may be of great help. Thank you very much.
Thank you, sir, for an erudite lecture and enlightening us on granuloma. I would like to invite Dr. Shubhra Dhar for the panel, as a moderator for the panel discussion. And Shubhra, you can call your panelists one by one and introduce them. I already introduced them. Saurabh is already there. I'm seeing his face. Vishwanath Bera is there. Shishir is there. And also the sirs, Dr. Gopinath and Dr. Manoj Singh to stay on.
Very good evening to all of you. My panelists are already there. They have already been introduced by Dr. Sudeep Das. So let us start with the clinico-pathological correlation of some cases where actually diagnostically quite difficult. So first of all, I'm going to show you the clinical pictures. Then I shall ask my panelists the clinical differential diagnosis. And then I shall show the histopathological pictures. We will see the histological pictures and then untie the diagnostic knots and come to a conclusive diagnosis. Just a second. You can hear me? All of you can hear me?
Yeah,
Yes, ma'am. Yes, ma'am.
You have now switched on your video, Dr. Subra. Now it has come.
It has come?
Yeah, it has come. You are audible.
But then my screen is not now moving.
It is visible, Subhati.
Click on screen, then next.
Go on to the next one, please.
Huh.
Now
So
it is coming.
Okay. Thank you very much. So this is the first case, 58-year-old male. He's a businessman by profession. He presented with coalescing erythematous, flat papules and plaques on his trunk and limbs. These lesions were moderately itchy. Patient is a known hypertensive and has hyperlipidemia, and the duration of the lesions was 4 months. So this is the clinical picture. Please look at it carefully. Look at the erythematous papuloplaque lesions, quite irregular, and they are coalescing. There is another picture. This is on the back. So I will want to know the clinical differential diagnosis. I will go to Dr. Saurav Singh first.
Good evening, ma'am. Am I audible?
Yes, good evening. Yes, you are.
Okay, so they seem like hundreds of papules and plaques, erythematous, infiltrated, shiny. So I would
Yes.
think of maybe, first of all, I would think of histiocytosis.
Okay.
Maybe non-Langerhans histiocytosis, something like that. And maybe histoid leprosy also, some cases. Although in histoid leprosy, we have more discrete lesions. These are more confluent. And maybe we can also think of some rare presentations of sarcoidosis. So I would remain in histiocyte domain for this in terms of differentials.
Okay. Dr. Shishir Das, you'd like to add something?
Yes, ma'am. Well, sarcoidosis is top of my list because some of the lesions there in the center of the back are somewhat annular, and I would also consider common differentials like lichen planus and psoriasis, partially treated, may present like this with less scaling and all these erythematous plaques coalescing into papules coalescing into plaques.
Okay. Dr. Vishwanath Behra?
Yeah, good evening, ma'am. Besides sarcoidosis, I think the popular GA granuloma annulare also I'll consider whether there is a popular plaque variety. They can sometimes they don't show the annular morphology very early in the disease. So besides sarcoidosis, popular GA, granuloma annulare, I'll consider, ma'am.
Okay, okay. So, Dr. Gopinath, would you like to add anything to the differential diagnosis that
Sarcoidosis, leprosy, granuloma annulare. These are my different.
okay. So, shall we move switch to the
My
histopathology?
only thing is granuloma annulare, would there be such large number of lesions occurring as crops?
There is a generalized granuloma annulare, so which can have hundreds of lesions. Generalized popular GA.
And the other thing, Subraji, you had given
Yes, sir.
indicator in the clinical history of hyperlipidemia and so on. Was that a red herring or was that an indication to something?
Sir, we'll see whether that was a red herring, whether you are right or not, we will see at the end. So, we have got a list of differential diagnosis, and everybody would agree that we must do a biopsy of this case to actually know what lies underneath, so that we can proceed with the patient management properly. Everybody agrees?
Yes.
Yes,
sure.
Yes.
Okay. So we come to the histopathology now. So a punch biopsy with a wealth of information. I want to know from Dr. Saurav
Yes,
where
sir.
the pathology lies. Whether
Yeah,
it
as
is
we can. Yes. So it seems that it is a granulomatous pathology. Basically, first of all, I like to classify as a reaction pattern. So we can see collection of histiocytes both in the upper and mid dermis.
Yes.
And at this power, I can't see the deeper dermis, but yes, it is there.
No, this is the scanner view, and you can see the deeper dermis. And you are right, that it's showing a granulomatous pattern. So the pathology lies in the dermis.
Yes.
And this is the low power. In the scanner view, you can see the entire punch, almost the entire punch biopsy, and this is the low power. So some part of the deeper dermis.
And it seems it is. Yes, ma'am. And it seems that it is forming some sort of a shape.
Yeah. So
they are
we will
trying
look
to
at the shape.
encircle
We'll
that
look at
area,
the shape.
basically.
Yes. We'll look at the shape now. I have the high power views now. On the left is the low power view, and on the right is the high power view. So can you describe? Saurabh, you're doing a good job.
Yeah.
So
Thank
can
you,
you
ma'am.
please describe?
Yeah. So basically, what we are able to see is a collection of histiocytes, and I can see some sort of a palisade, as well as it is going interstitial. I think interstitial infiltrate is something that we call when the cells go between the collagen bundles. So they are intersecting the collagen bundles also, and they are at the periphery also, almost forming like a arc, which was more clear on the scanner view. But now on higher power, we can see the cellular morphology. They are distinctly histiocytes, and hardly any lymphocytes or other cell types can be seen.
Yeah. So, shall Dr. Shishir Das, this question is for you. Shall we go for any special stain now?
Ma'am, we can do one reticulin stain and a mucin stain.
Sorry?
We can do a reticulin stain and a mucin stain.
Any other stain to where Saurabh was indicating that it is forming a pattern like palisaded granuloma?
Yes, a mucin stain should also be done, like colloidal iron or Alcian blue stain.
Yes. So we will see the special stain. These are some more high power views to show you the palisaded arrangement of the granulomas. There is an attempt to this giant cell formation. But you cannot call this a proper giant cell. Here also there is an attempt to form a giant cell. And this is the special stain, which is eliciting the increased mucin in the dermis. And probably Dr. Vishwanath Behera would have made the diagnosis without a biopsy. A very confident diagnosis. Would you say that you'll make this diagnosis without a biopsy, Dr. Vishwanath Behera?
I have seen a good number of cases of generalized GA, madam. So
Okay. So this is the only case of generalized granuloma annulare that I have seen. And this particular clinician, he always gives a very good history. When he sends a case, he gives a very good history. And this history was present that this patient is having hyperlipidemia. So, sir, Manoj Singh, sir, you were right. So the hint was lay in that particular history that the patient was hypertensive and had hyperlipidemia, because generalized GA can have hyperlipidemia. And I got this case for you all because of its unusual atypical presentation. And what is one thing that one must do when particularly you see this atypical presentation and particularly the disease is occurring in an old age? What should one do in this condition?
In terms of investigations, ma'am, are you asking?
Yes, for the patient. One must screen
Okay.
for
Yeah, diabetes.
malignancy. One must
Diabetes,
screen for
malignancy.
malignancy. Yes.
Mhm.
So moving on to the next case, 27-year-old male farmer presented with a plaque lesion on face. It was not associated with itching and the duration was of 1 year. So now I will reverse the order. I will ask Manoj Singh sir to describe what we are seeing here.
Probably sir is not
I
there.
think he's busy,
Okay,
ma'am. I think. Okay.
Okay,
This is-
Dr. Gopinath, please. Hello?
Yeah. It's an atrophic plaque on the face
Yes,
with
yes.
raised borders.
Yes.
Raised borders.
What
And,
about the scent?
Yeah, the central clearing is there.
Yeah.
Again, a granulomatous condition I would think of. I would like to rule out leprosy first.
Okay.
Biopsy is absolutely indicated.
Saurav, you'd like to add anything to the clinical differential
Yes, ma'am.
diagnosis?
As sir has rightly mentioned, it is showing central atrophy and raised plaque at the periphery. So I think we commonly see this pattern in tuberculosis, especially lupus vulgaris, and maybe we also see in BT leprosy in a reaction. So these would be my top two differentials: leprosy, BT in reaction, and TB, lupus vulgaris primarily. And maybe we can also again think of, because head and neck is a common site for sarcoidosis. So we know
Yes.
that sarcoidosis can also cause annular lesions. This is an annular plaque. So these three would be my differential.
Okay. Dr. Vishwanath and Dr. Shishir, you'd like to add anything? Dr. Shishir first.
Yes, ma'am. I think this lesson perfectly describes erythematous plaques on face. So we have all these 7 L differentials: loose, lupus, leprosy, leishmaniasis, and lymphoma. So all of these may be a possibility. So I am more inclined towards leprosy, and I have seen a few cutaneous leishmaniasis cases like PKDL present like this with unilateral involvement, and also there is some hypopigmented lesion on his left side also. So that may also be a possibility.
Okay, thank you. Dr. Vishwanath.
Madam, BT Hansen will be like first thing we'll rule out that is not a BT Hansen in possibly in reaction.
Okay.
Then as told by others, other possibility like face is very common set for many granuloma disorder, but first primary concern is to rule out that it's not BT Hansen in type 1 reaction.
Okay. So moving on to the histology now. We have finished with the clinical differential diagnosis. Dr. Gopinath, can you please describe the histology?
Yeah. Yes. It shows some amount of atrophy of the epidermis. You can see the dilated pilosebaceous orifices, and there is an infiltrate in the upper and mid dermis. In areas, it seems to be forming focal collections. Can we go to the next power?
Yeah.
These are the areas of the focal collections are seen. This appearance should make one think about a granulomatous lesion, that pale pink appearance of the histiocyte cytoplasm. So we are dealing with a granulomatous inflammation located in the upper and mid dermis. Do we have any more histopathology images? There is no evidence of necrosis, and the infiltrate. Do we have a high power? Yeah. So this is the, granuloma, which I was talking about. One can identify it in the scanner and low power view by the pink color of the cytoplasm. There is a good admixture of lymphocytes. We are seeing perhaps a multinucleate giant cell, but no foreign body type, a small multinucleate giant cell. No
Probably Langhans.
Yeah.
Langhans.
Probably Langhans giant cell. No foreign body type of giant cell, no eosinophils, no necrosis. And my first differential seeing the clinical image was Hansen's disease, borderline tuberculosis leprosy, but the histopathology doesn't really point towards leprosy because we are not seeing any neurovascular granuloma or periadenoidal granuloma. We have to think about other granulomatous conditions. As Dr. Saurabh said, it could be cutaneous tuberculosis.
This is another high power view.
It shows many lymphocytes and the histocytic collections are seen. Even classical epithelioid cells are also seen.
It looks pretty ill-defined in this area.
Yeah. Again, the granuloma is seen in a background of dense lymphoplasmacytic infiltrate. Cutaneous tuberculosis is my possibility.
So after looking at the histology, cutaneous tuberculosis becomes the first possibility.
First possibility. And because of the atrophic epidermis, absence of necrosis, I would think of lupus vulgaris.
Yes. So after doing a clinico-pathological correlation, the diagnosis in this case is lupus vulgaris. As Dr. Gopinath has rightly pointed out, there was no perivascular arrangement of the granulomas. There was no alignment along the appendages. But it was not very typical of lupus vulgaris either. In skin diseases, the problem is that not only the diseases look similar on the surface of the skin, when we do a biopsy, they also look similar under the microscope. So we really have to do a very good clinico-pathological correlation to come at a correct diagnosis.
Ma'am, may I add this one thing?
Yes. Yes, Saurabh.
Can you just go to the scanner view of this slide? Just one thing I wanted to add, scanner. Actually, I have noticed this over the years that, so as Manoj sir was taking a wonderful lecture, he mentioned that there is a confluence of infiltrate in the upper dermis whenever we see TB. And one thing I have noticed with some experience, I'm definitely not very experienced as per other senior here, but implantation is one way, like extrinsic implantation of TB. Then we tend to see more epidermal changes, like hyperkeratosis and thickening of epidermis. But when it is hematogenous, like it may have come from inside the body, then you see such not much hyperkeratosis. It may actually be atrophy. So, and also depends on the site of biopsy. If you have taken biopsy from maybe the atrophic center near the scarring part, it can show atrophy. But in the periphery, maybe more epidermal change. That was just my point.
Okay. So actually, when we see such annular plaque on the face, then a whole host of clinical differential diagnosis come to the mind, isn't it? Like sarcoidosis, like everybody pointed out. It can be sarcoidosis, it can be lupus vulgaris, it can be BT Hansen's, it can even be PKDL. Dr. Shishir has sent nice case of PKDL a few years back. So we have seen all that. But here, I think we can all go with the diagnosis of lupus vulgaris. We move on to the third case now. 63-year-old male presented with plaque lesion on the lateral part of lower abdomen. Duration was more than 5 years. So I will go to Dr. Vishwanath. What is your differential diagnosis now?
Madam, it looks like either BB Hansen in type 1 reaction possible. BB Hansen, BB leprosy, type 1 reaction. There is some Swiss cheese pattern appearance looking.
It is again showing some central clearing, isn't it?
Yes, like multifocal central clearing. So giving a Swiss cheese pattern. So either possibly BT has downgraded to BB or it is BB in type 1 reaction.
And the border is very well defined, isn't it?
Well defined. So it possibly BT has gone to BB possibly, or either BT or BB, madam.
Okay, so we must definitely do a biopsy, you know, isn't it?
Yes, ma'am.
To know what lies underneath. Anybody would like to add any other differential diagnosis? Dr. Gopinath?
No, I think it is a granulomatous lesion possibly. The duration is 5 years, such a long duration. Only solitary lesion, you said, isn't it?
Manoj sir is there?
Yeah.
Yes, sorry.
The only thing I'd like to add is that this, as he had mentioned, erythematous. So I think there is some kind of a active process going on. Could be a reaction in leprosy, in tuberculoid leprosy. There is a lot of erythema in the margin and in the substance also.
Okay, sir. Dr. Gopinath, I interrupted you. You were going to say something?
No, the duration you mentioned as 5 years.
5 years, yes.
Just a solitary lesion.
Yeah, solitary.
Biopsies should be very interesting. Let us see
Yes.
the histopathology.
So again, Shishir, Dr. Shishir, would you want to comment on the histology? What are we seeing here?
So
In
we
the
see a top
epidermis
heavy
and in the dermis,
infiltrate.
I don't want the diagnosis. I just want you to
I
say
think, ma'am, sorry to interrupt, ma'am. I would also like to keep TB for this, clinically.
yes.
Leprosy and TB both, because it is again an annular lesion.
Okay.
That's all. Sorry. Please proceed.
Yes, Dr. Shishir, I was asking what is the change that we are seeing in the epidermis here?
So in the scanner view, we see some type of acanthosis with a pseudo epitheliomatous hyperplasia like change.
Yes,
and a
almost.
top heavy infiltrate. This top heavy infiltrate of granulomatous infiltrate with numerous giant cells.
Yeah, plenty of giant cells.
Granuloma is almost almost lichenoid. So that kind of goes in favor of TB diagnosis. Sort of
Many giant cells are there, isn't it?
Yes, many.
So
all of these
now
are
we'll move.
Langerhans type of giant cells. Langerhans type of giant cells.
Yes, most of them are Langerhans type. Langerhans. So and plenty of lymphocytes are also there. But now you have the diagnosis.
You saw these in the lower power also.
Yes, sir.
Yes,
sir. Yeah. We could
it was
see
there.
that.
Yes. So here you have lymphocytes, and there is an attempt to giant cell formation. And here you have a nice Langerhans giant cells, and you find this thick walled. Saurabh, you're going to describe this? Yes.
Can you go back to low power? Actually, I don't know, my resolution is so poor.
Yes, here it was.
1, 2, 3, 3 to दिख रहे हैं
Yeah, just beneath the right hand side of the
I can see.
इधर भी एक दिख रहा है, इधर एक दिख रहा है.
उधर 2 है.
The top one also.
इसमें बहुत ज्यादा नहीं थे सर, बहुत ज्यादा नहीं थे.
Yeah.
आपके वाले स्लाइड्स में there were more. इसमें बहुत ज्यादा नहीं थे. but enough to make a diagnosis.
Yeah.
Yes.
Yes.
So
Yes.
these are thick-walled. Saurabh, you were going to say this, describe this?
No, ma'am, I was just using the word copper penny as
Yeah.
sir had
Yes.
mentioned during the lecture. So they are like classic. And
Yeah,
since
but
it's a colored fungus, so it is showing the brown color.
yeah,
It may be good to remind trainees that fungi generally don't take up stains, except
yes.
for the color fungi. They are all negative stains in H&E at least,
So
negatively stained.
these fungi are actually very easy to pick up on H&E stains. You need
Only
not
if
even
they are there in good amounts. Yes.
in good amount, yes. And that is what I always advocate, that if the number is scanty and you feel that it is chromoblastomycosis, you are unable to see chromoblastomycosis, then you do go for a special stain. But if you are able to identify the spores of the fungus, then there is no doubt that this is nothing but chromoblastomycosis.
And actually, one dictum for all granulomas: polarize it.
Okay.
All granulomas. If it is negative, then TB and leprosy are there. But for anything else, you should always polarize it, and you will see foreign bodies, fungi, all sorts of things may show up on the polarizing.
And one point that I would like to make over here is that chromoblastomycosis in textbooks actually, it is described that they usually present as verrucous lesions and they are a differential diagnosis for TBC. But more and more in this part of the country, we are seeing chromoblastomycosis presenting in such unusual manners. They are, I don't know the reason. It could be, I don't know, the climate change, or I don't know what is the reason.
For the past 20, 30 years, more and more patients are likely to come into you
They are
in an earlier phase.
Even
So
the anatomical site is little unusual. It is seen in the abdominal wall, isn't it?
Yes, anatomical site, the appearance of the plaque, sometimes they present as atrophic plaque, sometimes they present as this annular plaque, well-defined. Sometimes it is even misdiagnosed as granuloma annulare because of its annular plaque presentation. When it is small, and one case presented as a small solitary annular plaque on the neck region, and it was clinically diagnosed as granuloma annulare, but it turned out to be chromoblastomycosis. And this is my another, that atypical presentation wala chromoblastomycosis.
May I add that did we see many eosinophils among the infiltrate? I think we didn't.
We didn't. Even the histology is changing.
Yes. There were not many eosinophils. So if
Usually,
we miss the fungus, we go
then you
wrong
miss
with
the diagnosis actually. Yes. Very rightly pointed out. We move on to the next case. 22-year-old female presented with papuloplaque lesions on her forearms and abdomen. These lesions were associated with mild itching, and the duration was 6 months. One correction, that these are not papuloplaque lesion. This is a papular lesion. The lesions presented as papules as well as plaques. So on her abdomen, the plaques. Dr. Vishwanath?
Granuloma annular also, it looks like there are.
I'll interrupt you. Any difference? Like, did you notice any difference between the arm and the abdomen? Does it look that it belongs to the same person?
Arm, I could not appreciate. It's very blurry. I could not. Okay. Occasion, I think.
No, I'm not talking about the lesion. I'm talking about the arm. The arm looks like it belongs to a 22-year-old, but the abdomen looks like it belongs to a slightly old. I'm not slightly, much more older lady.
Okay.
So while making the presentation, I myself thought whether I have taken the right picture or not. Then I realized the top is the same, so it's the right picture. It belongs to the same person.
Clothes are same.
Because of the striate distancy, probably this abdominal picture looks as if it belongs to an older woman.
Maybe recent weight loss.
Okay. So I was asking Dr. Vishwanath.
Yeah, I like to keep granuloma annular here.
Okay. Too many annular lesions.
They are not annular, but it's a plaque
नीचे
type
वाले हैं
plaque, mostly plaque.
नीचे वाले हैं
Okay. Arm lesion you could not appreciate this.
Looks like papules, but the
Yeah.
characteristics is not quite visible. Looks like papules. Erythematous or reddish brown papules. They look like.
Okay. Okay. So we need to go for a biopsy, isn't it? Dr. Shishir, would you like to add anything?
I don't know, maybe we should also keep in mind mycosis fungoides may present like this. And nummular eczema is a very close differential for the abdominal lesions. And the lesions on the forearm and abdomen cannot be correlated like that. So we need to go for biopsy.
Okay. And Dr. Gopinath, please.
Lichen planus or lichenoid eruption, mildly pleuritic lesions, the young female.
Saurav, you would like to add something?
Ma'am, the abdominal lesions are also plaques, or they are quite flat and macular type? Because from the image, it's not very clear actually.
It was described as plaques,
Plaques,
papules
okay.
and plaques.
Mhm.
The image, it looks like patch.
Yeah, it is very thin, sir.
yeah
Not much raised.
Not
Yes.
not really elevated actually.
Not really.
and those two
Not
on the
much
left
raised.
side, the lower ones are actually annular also. Central clearing is there.
Yeah. Actually, considering the flat nature of lesions, I'm not very inclined towards granulomatous conditions here. I'm more in favor of maybe some drug-induced eruption or maybe patch stage of something, parapsoriasis or something like that. Because I think nummular also location is not a good one. Nummular eczema is more on the extremities, lower limbs. And in fact, if it is purely macular and steroid modified tinea also may look like this. Many conditions can look like this actually.
So we are done with the clinical differential diagnosis, and this is the histopathology biopsy that we see here.
Oh,
So anybody would like to describe this? Any volunteers?
Thankfully, it's not granulomatous.
So sort of
As
you
I
can
suspected.
describe what we are seeing.
Yes, actually, ma'am, it's not very clear, but yes, I can basically make out basket weave sort of hyperkeratosis, and I can make out
Sorry,
acanthosis.
I will interrupt you, Saurabh. You just
Yeah.
look at this pattern corneum here.
Yeah,
and
it's
this is
okay.
not basket
There
weave.
is
This is not.
okay. It's a mound of parakeratosis.
Yeah.
or-
Yes. It's a
Okay,
mound of
yeah.
parakeratosis.
Right. Okay, and
So-
lot of acanthosis actually, mild papillomatosis, and
that's right.
do I see some polarity change also
yes,
in the lower parts?
yes,
And dilated capillaries, of course, but I think it's an epidermal reaction pattern.
yes.
It's not dermal. The pathology is in the epidermis. I think there seems to be some atypia, loss of polarity, but higher power may show.
This is the higher power.
Okay. Yeah, I
Very
think,
nice. Very nice.
yeah, ma'am. I think there is loss of polarity. And there seems to be some,
Okay, I will give you one hint. Sometimes,
Hmm.
I'm showing in a laptop, it may look different like what you see under the microscope. So I will give you a hint
Yeah.
that
Okay.
you were right. The pathology lies in the epidermis.
Yeah.
And what you just describe what we are seeing here.
Right. Okay. So we can see that there is, if for the small section, we can say there is a mound of parakeratosis.
Yes.
And and there seem to be some inflammatory cells above that.
Yeah,
Below
it
that,
seems. It seems.
Yeah. So, and then you have this sort of acanthosis just beneath that, bulbous retiridges, thickened retiridges, and
Here,
tell-
the keratosis is orthokeratotic, isn't it?
yeah, there it is orthokeratosis. In the section on the left, probably has mound of parakeratosis. and there is some pallor to the cells.
So, okay.
Yeah.
I don't think we are reaching any conclusion from those from those pictures, isn't it? You all agree? So I
Right.
like to ask this question to Manoj sir first. Sir, in skin biopsies, we are limited to a small punch biopsy. So sometimes we feel, काश मुझे थोड़ा और दिखना चाहिए था इसमें. So what do we do in that case? कि कुछ और मिल जाए इसमें. So what do we do in that case?
You see it in the higher power and do a
सर
PA,
उसमें भी नहीं मिल रहा. हायर पावर में वो थोड़ा लग रहा है कि इसमें थोड़े
do
से
a PA
inflammatory cells
stain.
है. So how can we get some more information from a punch biopsy?
PA stain for
Yes, we can go for special stains. What
Yeah.
else can we do, sir?
तो हायर पावर में देखिए कुछ दिखेगा.
Sir, और कुछ करते हैं sir.
पोलराइज करेंगे.
Sir, you do that, but we all do that actually. When we are unable to make a diagnosis, we keep the slide for the next day. ये बोलकर we instruct the technician कि इसका एक deeper section ले लो. Don't we all do that,
Yeah.
sir?
Yeah. Step section.
Yes.
From which lesion this biopsy was done? From the papule or from the abdominal lesion?
Abdomen.
Very good question. Yes.
Abdomen.
Yes, it was done from the abdominal lesion. So I have done a deeper section.
Okay. Right.
Now look at this area.
Yeah. Exactly.
Look at this area. This is the low power view, and this is the no. This is the scanner view, and this is the low power view.
It is showing us spongiotic area.
It is showing a spongiotic area. Something has now, which was hidden, has now come to the surface.
Spongiotic vesicle. So
Yeah.
yeah,
It's not. It's a pustule.
yeah, it's
Look at
now
the
neutrophils are
cells.
seen now. Yes.
Yes.
With this
Look
power.
at the cells. Yes. So we
Spongiform
saw
pustule.
mounts of
Pogoj.
So the diagnosis is now turned out to be psoriasis. So
So it
probably
is
it was
treatment modified. Treatment modified.
probably it was a gutted psoriasis which has turned to a plaque psoriasis over the abdomen.
Fungal stain was negative.
On the forearm, probably it was a lesion of gutted psoriasis. And it is known that gutted psoriasis can change into the plaque form.
Yeah, but ma'am, I think absence of much scaling indicates that it is modified by treatment.
Probably partially.
Probably. But
Yeah.
another thing is, Saurabh, I want to tell you that the lesions were scaly. Probably in the photograph, it is
Okay.
not
In the image, it was
not
probably.
so much visible, because one of the differential diagnoses received was also pityriasis rosea. So fine scales were
Okay.
also present. Yes.
So
after doing a
Right.
clinical pathological correlation and talking with talking with my referring clinician, I was able to come to a diagnosis. So psoriasis was also one of his diagnoses. So everybody is convinced? I don't hear any yeses.
Yes, we have done a fungal stain, isn't it? It was negative.
Yes, fungal stain was negative. I should have included it. Because sometimes in fungal stain, you find a small pustule. I have seen that in case of tinea. But the past stain was negative.
And usually these type of lesions always get treated for tinea before coming to biopsy.
Yeah,
So-
that is also right. "60-year-old female presented with annular plaque lesion with well-defined raised margins associated with moderate itching. Patient had these lesions had a waxing and waning course. Duration was of 3 years. And the lesions did not worsen on sun exposure. These are the lesions on the lady's back. And the lesions came at different points. These are the older lesions. These are the newer lesions. Vishwanath, can you start the clinical description and the differential diagnosis?
Old age from back, granuloma multiforme. And since you are telling there is no exposure, like sun deprivation. So old age actinic granuloma is commonly thought, but it's a back. So granuloma multiforme and like annular plaques are coalescing are very, very large.
Okay. Annular granuloma multiforme, you said.
Granuloma multiforme.
Granuloma multiforme. And Dr. Shishir, you'd like to add something?
Ma'am, the clinical presentation is expansile erythematous annular plaque, and the center has some hyperpigmentation, so it falls under this umbrella term like figure eight erythemas. So you
Yes.
should consider all types of figure eight erythemas, especially erythema annulari centrifugum, deep variant, and also granuloma annulari could present like that.
Okay. These are some of the lesions. These lesions are slightly older lesions on the arm and on the abdomen.
Ma'am, is there a timeline where
May I add,
patients
ma'am?
have-
Yes.
Ma'am, is there a timeline from when was the first photo taken and when was the second photo taken? So how
At
fast
an
are they
interval,
growing?
I will tell you, at an interval of 2 months.
Yeah, I think if I may add, ma'am,
Mm-hmm.
the lesions are very large.
Yes.
So I think if we have to keep two variants, basically one spectrum may be a granulomatous one, the other one, as Sisir has mentioned, maybe
Yes.
defigurate erythemas.
Correct.
So among the granulomatous, I think the large lesions are seen in some conditions like the annular elastolytic giant cell granuloma. And
Yes.
actually, AEGCG would show bigger lesions than GA, basically, as per the usual presentation and morphology. So I would add that also to the list, AEGCG.
Okay. You have used one short form, please.
Annular elastolytic giant cell granuloma.
Yes. Sometimes, you know, I am slow at catching those short
Yeah,
forms.
yeah, yeah. And I am slow at speaking, ma'am. So I use short form.
Dr. Gopinath, please.
Yeah, I think the clue is in the history that it is waxing and waning of lesions. So, first possibility would be an annular erythema, but I mean, because I'm a pathologist, I'm saying that I would like to screen the patient, do a complete blood count and things like that before we do the biopsy to look for any underlying pathology and systemic disorder.
Okay.
I would also like to do that.
Manoj sir?
No, nothing to add.
Okay. So we've finished with the list of clinical differential diagnosis. Now, this is what the biopsy showed.
Great.
Saurabh?
Yeah. This is again non-granulomatous. So we can see the pathology is probably in the perivascular location.
Okay. We can see some infiltrate in this.
Yeah, we can see perivascular lymphocytic lymphomononuclear infiltrate. The epidermis looks banal, normal, basket weave, and
Manoj sir,
normal.
can we call this as a coat sleeve?
Yes?
Can we call this pattern as coat sleeve?
No, I
Coat
don't.
sleeve infiltrate.
No, no.
Very mild.
Not that tightly cuffed around the blood vessel, isn't it?
Leprosy actually is a distinct. I mean, you don't have any problem in correlating this. This is perivascular. I mean, that is actually a perivascular inflammation, which is quite marked. So that you see in leprosy, and for some reason you see it more in leprosy, more inflammation, more coat sleeve. This is a very thin coat sleeve. That is a big, thick coat sleeve.
So I couldn't find any granuloma. I didn't think on histology that this was leprosy. So I saw the clinical picture and I thought maybe like Shishir, I thought this was a case of figure eight erythema. So,
ma'am, there are some eosinophils conspicuous around this perivascular infiltrate. So
I didn't really see the eosinophils here.
Yes, ma'am.
It was predominantly a lymphocytic infiltrate.
Yeah, predominantly lymphocyte, but there are more eosinophils than I would like to be present here. So
It's present.
You think so?
I can see at
I
least
don't think
2 or
so,
3
because
on
in
the left side.
erythema annularis centrifugum, you can find few eosinophils admixed with the lymphocytic infiltrate. So I thought this was a case of figurate erythema.
Yes,
Yes.
I think so.
Yeah, if it
Yeah.
is leprosy, no, it has to be in the multibacillary spectrum. Patient is having large number of lesions. That is not seen in the histology. So I think
Yeah.
that way we can rule out leprosy from this biopsy. Of course,
Doing a clinico-pathological correlation, we can say that this is a case of figurate erythema. I
yeah,
don't think
likely to be.
and I don't like to write that term non-specific dermatitis at all. I don't like that term. I don't never use that term actually. So I have to give out a diagnosis. So if I give out a diagnosis, I will sign this out as figurate erythema.
Madam, will not it fit to arterial vasculitis?
Yes, that was
Okay.
that was what I was thinking too.
So I signed out the report as figurate erythema, probably ESE. But then my doctor was not very satisfied and he repeated the biopsy on a fresh lesion.
Okay.
Now the picture has got slightly changed.
Both
Now, Dr. Vishwanath, would you like to describe?
Yes, ma'am. The scanner view shows like normal looking or mild atrophic epidermis with increased basal pigmentation looks like. And there is upper and lower perivascular and periodontic gel moderate degree inflammatory infiltrate.
Much more than what we saw in the first biopsy, isn't
In the
it?
last slide, yeah.
And the little low power, I think, shows there is fibrin, there is perivascular inflammatory infiltrate. I am not able to see what type, but definitely there
No,
is
I will.
fibrin. Yes, ma'am. Looks
And
like there is
anything,
a fibrin deposition.
it looks as if
between
the collagen looks more eosinophilic, isn't it?
eosinophilic. So it looks eosinophilic, and the cellular I am not able to
Okay.
filtrate hyper. Okay. So
Okay.
here it shows
Wow.
mainly
Wow.
very
Wow.
adenine lymphocyte infiltration with some degree showing there is a necrobiosis also. The above the infiltrate there is a necrobiosis, and here there is lot of eosinophil cells.
Okay. So I would like Dr. Gopinath to take up the description now, please.
I'm afraid I don't agree with collagenolisis per se, but there is that the low power appearance of the intense pink color could be due to the large number of eosinophils that we are seeing in the high power.
Yes. Now,
And,
if Shishir says that plenty of eosinophils can be seen, I will agree.
Yeah.
Plenty of eosinophils are seen, interstitial as well as perivascular.
Yes.
Dr.
All these cells are all, because I have the cursor, so I am just
Yeah.
showing the eosinophils. So
Very
these are
large
all
number.
eosinophils.
Yeah.
Almost
Lot of it.
lot
Where-
of eosinophils are there.
Were there any flame figures?
Let us see. This is another high power
That's
view.
a huge amount of it.
Yeah.
Huge amount of eosinophils. And the collagen does look more eosinophilic. Like flame
Yes.
figures, we call them flame figures only when they are present in a particular configuration and when
Yes.
it is not
Yes.
so extensive.
Yes.
It stands out against paler staining collagen. But here
Collagen.
almost the entire collagen is stained pink
Pink. Yeah.
because of the huge number of eosinophils.
Hmm.
Could this be one type of an eosinophilic dermatitis?
Yes,
It is.
I think you
Yeah.
are on the right track, Dr. Gopinath. So this is
Yes. Could be a type of eosinophilic dermatitis. Now,
yes.
see, why at the outset, why I suggested that we should work up the patient for any internal problem. I had seen one similar, almost similar clinical picture in a middle-aged lady who presented with eosinophilic dermatitis, and on workup, she was diagnosed to have chronic lymphocytic leukemia, CLL associated with eosinophilic dermatitis. I remember that case. That is why when I first saw the clinical picture, I was suggesting that we should work up the patient more
Okay,
or any
okay.
systemic involvement. Yeah, with the
I
again,
will go back to my referring dermatologist and suggest that that this patient should be worked up for the hematological workup of this patient should be done.
Yes.
Very good information.
Even
you,
I
doctor.
have one suggestion, ma'am, if I
Yes.
may add. Actually, this amount of eosinophilia actually goes against EAC. This is too much. Lot of eosinophils are there.
No,
So
And
EAC, you mean erythema annulare centrifugum?
yeah. Annular centrifugum. These
So on the
annular
second,
erythemas can include a lot of variable disorders. It can
yes.
even include urticaria, basically urticarial vasculitis sometimes. Even some lymphomas present as annular erythemas. So, but
Okay.
EAC in particular, if we talk about figurate erythema, it is a broad term. But if we
Yes.
talk about EAC, it is a very specific disorder, and I think this amount of eosinophils should allow us to basically work up for eosinophil.
We did not make a diagnosis of EAC.
Look at the diagnosis.
Sir, it's there on the slide, sir.
What
So
is
that's why
written there?
I was begging to differ that I don't think it is it may be final diagnosis. Maybe it is a diagnosis under process. So we may have to evaluate.
Saurabh, just a second. The second biopsy was done, and the doctor specifically told me that he had discussed the case with his dermatological colleagues, and they wanted to rule out eosinophilic annular erythema. So with these findings, in the second biopsy, when I received the second biopsy with these findings, I reported the case as consistent with eosinophilic annular erythema.
Right. Ma'am, I was again saying this that this is fine, but sometimes these disorders evolve and the lesions may not remain annular in future. So we need a workup, like Nand Kumar sir said. I agree with
That
him.
is true. That is true. That is what I
It
told.
should be worked up for a hypereosinophilic syndrome also, which has many causes.
Correct.
Yes.
Actually, between the two biopsies, you are seeing the evolution. So I'm sure.
Actually.
Part of
it is going to evolve further, yes.
As part of your workup, you will do another biopsy, and I'm sure you will. And I think that will be very valuable to compare the three biopsies also and the clinical.
Yes, that will be very interesting.
Together with the blood workup.
So again, biopsy gives many answers. So it's always good to go for biopsies. Sometimes repeat biopsies are helpful. So, and this is a relatively newer entity that has been described. I read up this case, and I'm surprised that nobody is mentioning Wells syndrome. Like some people consider this as a belonging to the spectrum of diseases under
Wells syndrome. Right.
Actually, Shubhra, I spent my life being spoiled at the All India Institute. And it's only now that I've stepped out into the big wide world that I start educating dermatologists that pathology gives you all the answers. Please buy
all the answers, sir. I agree with you.
There's a large number of dermatologists who are just, kind of going ahead and treating.
Yeah.
And, it's only when the patient.
Not the dermatologist here, not the dermatologist associated with me.
The setup is different. In our area, in the private area, number of skin biopsies is very, very
true, sir.
Very infrequent.
And sometimes we get so much information when a biopsy is done. Most of the times, actually. So we are now moving. We have reached the last case, actually. And this is an 8-year-old male child presented with papillomatous pedunculated growth on upper back. He had no other associated symptoms. The lesions first appeared 2 years back, and the lesion actually appeared 2 years back, and it increased in size slowly to reach the present size. This is the lesion on the back. So can I have the differential diagnosis? I'll start with Shishir.
So, the pedunculated red, slightly keratotic lesion. So, my first DD will be pyogenic granuloma. Then maybe solitary papular angiokeratoma. Uh, Sometimes some deep fungal infection may also look like this, but should not be solitary also. So how long was this present?
2 years.
4 years.
2 years. 2 years.
2 years.
So this actually had
Okay.
come with the differential diagnosis, with the clinical provisional diagnosis of a pyogenic granuloma.
So I don't think a pyogenic granuloma would stay for 2 years like this on the back also. I think I'll go with solitary papillary angiokeratoma and also verrucous hemangioma.
Okay. Dr.
The pedun-
Vishwanath?
the pedunculated lipoma.
Pedunculated lipoma. It was got Dr. Gopinath.
Madam, I'll like to
Oh,
have
sorry,
another.
sorry. Yes, tell me.
Yeah,
You
I'll like
said
to have
you
to
pedunculated
history of
lipoma?
any immunosuppression, madam.
Okay. No, there was no immunosuppression.
So I think one of the things I'll think of whether it's a solitary. It to me it looks whether it's a vascular lesion. To me, more look like vascular lesion. So it can be CN solitary epithelial angiomatous nodule or bacillary angiomatous if the patient has immunosuppression, or we can think of one adenic gel tumor. I was thinking whether it can be syringocystoderma papilliferum. This will be my three.
Okay. Dr. Gopinath?
No, I was just suggesting possibility of a pedunculated lipoma could also be considered.
Okay.
That's all.
Okay.
Yeah.
So some kind of tumor.
Ma'am,
Everybody,
may I add, ma'am?
everybody agree. Saurabh? Yes.
Yes, ma'am. I think we should consider also that this is a child. That is the most important consideration. And it seems to be a vascular lesion, but I think it may also be a secondary change over a pre-existing nevus, which may be a nevus sebaceous or some organoid nevus. So scap can be one possibility. According to me, syringocystoadenoma papilliferum can be one
that
possibility.
short form I know because I've
Yeah.
received pro formas where they mention scap. Some.
Yes, sir. Sorry to say. So that is one, and another is vascular lesion, but not PG. Definitely, I am not in favor of pyogenic granuloma, considering the duration, because till now it should have had the collarate and it should have started to bleed. So not really like that. But yes, we can think of maybe verrucous hemangioma. It's not a good site for that, but verrucous hemangioma, angiokeratoma, these can be suspected, according to me.
So now we are done with the clinical differential diagnosis. I will go to Manoj sir straight away. Sir, can you please describe the histology?
Well, these are large lobules of some tumor cell proliferation. They seem to be sparing the epidermis in most of the areas. In this area, they are actually pushing up the epidermis and going deep into the subcutaneous tissue also. What these cells are, of course, one can't make out here. One can make out here now. These are spindle-shaped cells, elongated cells, and the lobules are actually going in between. There are fat spaces, and
So these are probably blood vessels, sir.
Okay, you can make out in the lower
and
part.
This is the epidermis. There is like consumption of the epidermis. Epidermis is almost destroyed over here, and probably some frictional changes have taken place on the surface.
Yeah. And
I think it's the crust, sir.
You saw it on the clinical photograph also.
The lower part actually shows, oh, nice. These nests are present, and nests of spindle cells.
Yeah.
So I would think of some kind of a. I think I saw pigment in the earlier slide also associated with this cell. So I would think of some kind of pseudomelanoma or Spitz nevus. Even though Spitz nevus classically, there you have the pigment. the spindle cell element is less common, and you usually have a mixture of spindle cells and epithelioid cells. I'm sure you'll see some of these somewhere, the epithelioid cells, but predominantly spindle cell pattern. And yeah, the reason it's called a pseudomelanoma, of course, is because of these epithelioid cells, because the cells may look like these are the spindle cells. It doesn't seem to be a very high rate of mitosis. There is significant inflammation scattered throughout in areas, and pigment is there in some of the cells. And you may note that the pigment is actually much more in the upper part, in the area below the epidermis. And this is not, so prominent in the lower parts of this lesion. Yeah, I would
So
go
pigment is there, but pigment is not that heavy.
Yeah. So do you have, Shubhra, some area, some of this showing the high power in the low? Oh, so nice. What
Sir,
stain is
this is
that?
the high power view. This is high power
Hey,
view, and this
is
is the
this lower
special
and upper?
stain.
The one before, is this upper part?
Yeah, this is the upper part.
This is lower.
This is the epidermis,
So,
and you can see that the cells
So-
are coming out from the junction of the epidermis and the dermis.
so this is a benign lesion. Let me tell you that. This is a benign lesion, not a
And
malignant.
it is showing some junctional activity here.
That's okay. That doesn't bother me. That doesn't bother me. But in melanomas, I'm not sure whether any books have described this or not. But in one of my seminars, in IAPM seminars, actually, I had done some, cell area counting of cells in the lowermost part and the uppermost part. Particularly in these lesions, these lesions which may have epithelioid cells and so on, where the problem of a pseudomelanoma is very significant. At first sight, it may look like it doesn't look like like ordinary nevus.
Yes, sir.
If you compare, measure the average circumference or diameter of cells in the upper part and the lower part, you'll always see a difference.
Yeah.
Classic picture of cells maturing from below to above. You see this here. Here, if these are the lower part picture. The cells are
Yeah, this is the lower part.
cells are small, and this is the so-called neuroid appearance in the lesion. And the upper part is the well-differentiated one. Here, actually, again, you're not seeing the classic nesting of a nevus, but you are seeing this spindle-shaped differentiation. Shubhra, was there any epithelioid cell area also in this?
It was majorly
Majorly
spindloid cells were there majorly.
So yeah, because you see, our problem is in India, we have brown skins.
Some nesting is there, sir.
Nesting is distinctly there. Nesting is there. But our problem is that we see these, lesions so rather
very infrequently.
So, we don't know what we are talking about. We always have to, kind of look at textbooks and consult each other.
Actually,
whereas these...
I had to take second opinion in this case.
Absolutely, you must. Absolutely, you must.
I had actually referred the case to Dr. Sarah Edward. So, and there was no pagetoid spread also. This is another point that I want to make.
Sir, may I add, sir?
Yes.
Ma'am?
Yes.
Ma'am, I also noticed that, okay, you're showing the IHC. It's fine.
IHC,
I also noticed that the spindle cell architecture is right from top to bottom.
Yeah.
So that is not the usual way for the usual melanocytic nevi that we have.
There's not.
Another thing, Saurabh, I want to tell you here.
One more thing, ma'am. Okay, please go ahead.
I will tell you why you are not being able to see the top to bottom thing here, because it was not globular. It was a globular swelling. It was pedunculated. So I really could not go to that depth of the dermis.
But I think it is one thing is for sure, since it is a pigment producing cell line. So it is melanocytic. neoplasm, and probably a spindle cell melanocytic neoplasm, and maybe a nevus, as it's there in a child.
Saurabh, what do you mean by spindle cell melanocytic lesion?
Sir, actually, there are
From a nevus.
yes, sir. Yes, sir. Basically, I am trying to name the nevus because there is a spindle cell melanocytic nevus of Reed's nevus.
And that's a
Actually,
variant of Spitz nevus.
that's a variant of Spitz nevus, but often it is clubbed as Spitz only, but it is a sub-variant. So I am actually thinking of that because there was one focus of
And I think
junctional activity.
you are on the right track.
Because
S100
it is
was positive,
one,
and
yes,
KI67, sorry for interrupting,
yes,
KI67,
ma'am.
see that there is no activity, almost no
No
activity.
activity. Yeah,
So
yeah,
there is
yeah,
no
yeah.
mitosis. And we can safely conclude that this is a benign lesion. But
Benign.
believe me, I was really, when I saw this case, I was totally out of my wits, what to do, what to report it as. I could also make out that this is a case of I also could make out that this is a benign lesion, definitely. But then I wanted to take a second opinion because I had not
Yes,
seen
yes.
any Spitz nevus of this variant.
Another thing is, ma'am, that Spitz shows a lot of epidermal bodies and scatter, Spitzoid scatter that we found.
Yes.
Yes, camino bodies and Spitzoid
They were
scatter in
absent.
the, that was absent in this.
case.
Yeah.
They were absent. But still, this report, I signed it out as consistent with Spitz nevus. I didn't want to scare the clinician. I didn't want the patient to undergo any other, mutilating surgery or anything, because in all probability, this is going to behave in a benign fashion and will not come back.
So it's a learning point also for us, ma'am, that for pediatric populations, this presentation nevus should be the first differential.
Yes, it is. It may not be the first differential. It can be a differential,
for
and you should always go for go for a biopsy. So that brings us to the end of this panel discussion. Thank you very much for your active participation.
Thank you, Subhradi. And later, quite later.
Thank you, ma'am.
Thank you for giving me this opportunity. Actually, I forgot to
I would
thank
just shortly invite Dr. Kaushik Lahiri, the Chief Advisor of this Dharma Adhyayan program, to deliver a few just a short note on the today's program. And before Shuchibroto Das, our secretary, finishes of the program. We have just one declaration to make. On 26th of May, we'll be having a program, this Dharma Adhyayan Series 4, which is fully moderated by the IADable female dermatologist. The lady dermatologist will be completely and headed by Dr. Sujata Sindhu. And 23rd June, we are having the 5th edition, that is the new molecules of dermatology. Now, over to Kaushik Da. Kaushik Da ache? Where is Dr. Kaushik Lahiri?
Kaushik is not there, I think. Go ahead.
Okay. He has left. So, Shuchibroto, are you there?
Yes.
Please deliver the vote of thanks.
Thank you, sir. On behalf of IADable West Bengal, I express my regards and heartfelt gratitude to all our erudite faculties, both national and local, for making this third session of Dharma Adhyayan, dermatopathology, a complete success. I'd like to thank all the attendees for their participation in this very interesting but quite difficult subject. The discussion was practically very impressive and immense knowledgeful. I am thankful to Dr. Nandkumar Gopinath sir for clear elucidation of basal membrane for different dermatological disorders, to Dr. Manoj Kumar Singh sir for removing the curtain of mystifying granulomas, to Dr. Subhradhar madam for nice moderation of panel discussion on some most difficult and confusing skin conditions, and all panelists include Dr. Vishnu Pera, Dr. Saurabh Singh, and Dr. Sisitas for their insightful thoughts. I'd also like to thank our dynamic president, Dr. Sandeepan Dar sir, our inspirational past president, Dr. Kaushik Lahiri sir, and ever youth, Dr. Sudeep Das sir. At the end, I'd like to thank Pulsan Dharma for their wholehearted support to make this program possible, and also all our office staffs. Good night.
Thank you. Quite late at night.
Thank you.
All.
Thank you, everybody.
Thank you, everyone.
All.
Thank you. Thank you. Good night. Thank you.
Good night.
everybody.
Good night.
Good night, sir.
Thank you. Thank you. Good night.